I'm Dr. Anthony Maloof of Eyes and Faces and Corneal and Oculoplastic Surgery, and welcome to this video edition on fixing radial keratotomy vision loss. So what is that? Well, for those of you who have undergone radial keratotomy, you may have noticed that your vision is changing over time, and unfortunately it tends to do that. And the reason is the design of the surgery itself. So what is radial keratotomy? Well, if you imagine a circle, radial is like a radius, like a pi. You might remember pi r squared. What is the radius? It's radial incisions around the circle that is the front of the eye. So radial incisions. And the principle is this: if you cut into something, you weaken it. If you cut into steel enough, you can bend it. You cut into the cornea and you can change its shape. The problem is the change you get isn't stable. In fact, it is unstable. And the problem with instability is that instability changes over time, your vision changes, and it's really hard to fix. So people with radial keratotomy will often go, they get a bit older, it's 30 years old, they might be in their 60s, and they're told you need a cataract operation. They have the cataract surgery and the vision still isn't right. And they complain. And what do you do after that? Well, you fix the problem itself, and this is what this video is about. So how to fix a radial keratotomy cornea? Well, as you can probably guess, it's with surgery, and the surgery is stromal transplantation. You've destroyed the front of the eye. Here is a model of the eye. You've destroyed the front. Rather than replace the whole eye, I replace part of the eye. And that is layer transplantation. The difficulty in radial keratotomy is this: the whole cornea is weak. You've got to stitch a healthy cornea into a weak cornea. And I'll show you that. You'll see it here in the video. So let's have a look. Here we go. So we'll start this up. And here you see the dissection. Note the little incisions that are radial, they're going out, and it looks like a pizza pie, and that's exactly what it is. It's a pizza pie. So I'm going to have a careful dissection. Now right here where you see me start at this edge, it perforated. One of the incisions had gone through. So suddenly I've got to dissect a cornea that goes flat. So I'm putting air in the eye. I'm putting air alternating with saline. Air alternating with saline. I want the endothelial cells drunk with saline. I don't want them dry on a vine. Okay. So here we go, I'm dissecting all the way around, and notice how the tissue is breaking up into slices of pie. That's exactly what it is. And note the tissue underneath. There you can see it, slice of pie. And it's not easy to dissect. You've just got to sit back and enjoy the ride. And it takes a long time. This case took about 2 hours. Gradually working down to the pre-decimase plane. Note, remember this was a perforated eye, so I had to put an air bubble in, and I also put viscoelastic in to support the chamber and continue the dissection. It's very easy to give up and convert it to a full transplant, but we did it. There it is. There's your dissection. You'll see an air bubble in the eye, and now the laborious process of suturing begins. You're suturing really, really, really good tissue into really flaccid tissue. So this suturing is really tricky. It's different from normal one. You notice you can see that I've put 2 sutures opposing each other, and you just got to keep going around, and all of them get replaced until you've got the right shape and you've got the right tension. The tissue is so flaccid you can't predict. There's no nomograms or algorithms. You've got to judge each one as you put it in. So you put it in and then change it. Notice there's an air bubble in the chamber. That pushes the decimates back up against the tissue because there is a micro perforation. It doesn't stay there. I constantly swap it out with saline, back, forth, back, forth. But I'm just until I'm happy that it sticks, and in this case it stuck beautifully. Look how many stitches there are. It's going in, heaps of stitches, as you can see. And they've all been replaced and many times to get that shape right, because I can't predict how the host tissue is going to work. But we're getting there, and towards the end it looks really, really nice. When I saw him post-operatively, beautifully clear cornea, completely epithelialized. Vision is about the same. And here's the thing that happens. You have a very unstable anterior segment. These don't respond like any other corneas, but what I want to do is remove endothelial rejection, endothelial failure, cataract, all that other stuff that goes with full transplantation. So really the issue here is that these patients are on a long road to recovery, and the longer they delay it, the longer it's going to take. Once they present, if they've got poor vision and a cataract, they really need to get their cornea fixed first and stabilized. It takes about 2 years for stability. I say to my stromal transplant patients 3 to 18 months, but for the radial keratotomy, it takes longer. And what you hope is that all that irregular cornea in the outside sticks to this nice, healthy cornea. And once that happens, you're fine. And those people have a stable shape. And then they can go and have cataract surgery and get really good return of vision. But they've got to invest their time. They've got to follow their drops, do exactly as I say, and they'll get there. It just takes time. There's no wow factor here, but when you look at it 2 years down the road, you just go, wow. All right, well, that's how to fix radial keratotomy vision. I'm Dr. Anthony Maloof, advising faces and corneal plastic surgery in Sydney, and I hope that's been of use.